Thank you very much, Sabina. And yeah, it's a great pleasure to be here today and in this meeting, which is really a very refreshing meeting after some of the ones I've been to recently. And the start that we had, I think, has taken us off well. Aiming for wisdom and healing as core concepts. I hope that will emerge as a theme through what I talk about. Because really, I'm going to tell you my experience of learning to, I hope, nurture wisdom in practice and some of the things. There's an awful lot here, so I have chosen to use PowerPoint. I have to say I've become very unused to using PowerPoint these days and sometimes feel very uncomfortable because my educator, collaborator, was very insistent I didn't use it. But actually, when there's a lot to put in, I think it's actually a useful way of sharing it. So I'm going to do that. Nurturing practical wisdom, and perhaps the core concept of understanding the difference between cure and healing is perhaps important, but also very important in terms of how we bring up our young. And like everybody who's talked already today, I think the bringing up of our young doctors for the future and for our care, not least being rather selfish about it, is actually very important. I offered you two questions, I think. How does your specialty curriculum introduce the idea of wisdom in practice? And do you formally teach phronesis in practice at the current time? And if you don't, do you think you should? I'm not going to expand on that anymore because those are questions to you. And I hope we'll have a chance to discuss them in detail along with the other questions as the time goes on. My journey in this whole process, because it really started firstly by having to really take up the idea of what educational thinking is all about. I was a vascular surgeon in Chester. I was also very involved in educational activities throughout my career. I was a postgraduate dean, I was on the college council, I ran various projects throughout the country. I was involved in curriculum. I led the curriculum project for surgical care practitioners, an interesting activity across the healthcare professions. But I did actually get put on the spot 20 odd years ago by the college because they claimed they were writing a new curriculum. And creating and using resources to teach wisdom became actually quite important. As a surgeon, I never had much problem in deciding whether this person here could operate. There's much actually activity about skills and whether people can do it. It may sound odd to those who don't understand skills, but actually if you're working with people all the time, you know whether or not, and Ashok is nodding his head there, you know whether they can actually hold a knife and fork properly. It becomes very obvious. What you can't do is decide what's going on in here at the time, and particularly at the time when they're in the operating theatre. And that was my problem. I said, their observable action is triggered by a judgment. Where does that judgment come from? It may be that they're going to copy the great Mrs. de Cossart in actually what they're going to do today, but that's not good enough actually when she isn't around or they meet a situation that they haven't met with her before. How are they going to have their own agency? And I think it was Ed mentioned agency at the end of his talk there. How do we give them their own agency of being capable, safely, and in the interests of patients, being able to make their own judgments? And so I made the request to my newfound colleague about how I could teach judgment. All I wanted to know in 2001 was the way to teach professional judgment. And I was working with an educationist who had written about this in other healthcare professions. And how do I know what they're thinking? I think they thought this was going to be a 6 months idea when I would come out with half a dozen ideas of how to do it. I am here 20 odd years later and I'm still discovering things about what I'm not doing right and what I should be doing. So what I'm going to tell you is where I am now and some of the resources that we created, which I used in clinical practice with trainees, that I have used since I retired from my clinical practice, and I still continue to teach and run programs of teaching decision-making, reflective practice, and a course called Medical Supervision Matters, which is about actually making teachers of those in clinical practice better teachers. My experience with Della, my colleague, in the early 2000s was actually teaching trainees about clinical judgment and wisdom, and then suddenly discovering that they knew more than their bosses. And I have to say that led us into some very uncomfortable situations. And so I went backwards, and since then have been concentrating very much on a point that I think is important, which is about teaching the teachers. Because if the trainees don't have the right teacher, they will go wrong. So, but first I had to actually deepen my education understanding, because the immersion I had in this over the last 20 years was quite important. I'm not going to dwell on it, but I'm going to give you some headings of under which it felt. Theorizing practice as distinct from applying theory to practice. Thinking like a teacher. Worthwhile education. Teaching in the moral mode of practice. I was quite interested to see on the website here, in this very important place, they put theory before practice. And if you ask most people about what you learn, they say you learn the theory and you apply it to practice. I worked with an educator who banned the word apply. She said you cannot apply theory to practice because every practical situation is different. It has never been the same before. It is not a binary activity. And what you have to do in that practice is to judge what is necessary, whether that's in a clinical situation or in an educational teaching situation. And so really theorizing practice became quite important, because what we did in order to create these resources is to observe practice, mine particularly, and to create the resources from it. So we were actually theorizing what the practice of a surgeon at that particular time was in terms of their thinking and their actions, and then actually creating models that were useful resources in teaching these methods. Thinking like a teacher, and in the last 15 years, particularly running a master's course and teaching the courses that I do, I have to say this concept of changing the mindset of what those who teach young doctors in clinical practice think they should be doing into thinking like a teacher has been quite interesting. It is actually the complete reverse of what is happening. You do not unload all your expert knowledge into the mind of the other. You actually have to bring out of the other what they know and to grow in the concept of the greenery that we've already heard about and the growing plants. You have to grow that individual as if they were a plant, feed them with the right stuff and actually allow them to develop their own leaves, their own agency, and be able to take off. Worthwhile education, well, what is that all about? Well, it is exactly about bringing out of the individual what they're capable of encouraging critique, of encouraging them to think outside the box, of encouraging them to actually look at the wider perspectives of what is happening. I would argue to you at the moment, we don't do that. We don't educate, we train. We close the minds of young doctors into boxed compartments where they have to follow a strict pattern. And since I was involved in curriculum development of the College of Surgeons at the beginning of this century, I am ashamed, actually, at the way that postgraduate education in clinical practice has evolved, because it actually has created very much a box-minded system. And I would argue that some of the unrest that we are seeing amongst our young doctors at the moment is a consequence of that. Teaching in the moral mode of practice. Well, this is nothing to do with the morals and the activities of individuals, but it is the moral intentions of the practice of teaching. Just as we have moral intentions in the practice of medicine that we've heard already from Ed and from Sabina. the moral intentions of the teacher, we would argue, must be to act, to create, and to offer worthwhile education. So in this process then, following my development in those thoughts, and I've just given you an overview of what that meant, but there were many hours spent discussing this, many books read, many arguments, many glasses of wine swallowed in order for me to try and actually come to terms with a very new way of thinking about how you teach. We created several resources: the clinical thinking pathway, the qualities of professional judgment. We created a suite of heuristics called the Invisibles, and I'll explain about all of these in a moment. Rainbow writing and transformative reflection for physicians and surgeons, which is the latest edition that we wrote and published in 2020, which summarizes quite a lot of the thinking that is going on here. But these are resources that I have used and actually work. I'll tell you a little bit more about them. First of all, I'll just go back to what we've already been talking about, because old Aristotle then came into my thinking. I'm not a philosopher, and I'm not actually steeped in philosophical academe, but I really have become engaged with these ideas we've already heard about, the forms of reasoning that Aristotle offered: theoretical reasoning, technical reasoning, and practical reasoning, episteme, techno, and phronesis. I've coloured the practical reasoning in one because this hit me in the face as soon as I actually was introduced to it and began to think about it, that actually this is what we do. And all of the resources you'll hear me talk about, when offered to doctors in a form, one form or another, actually they say, well, we do that anyway. Well, yes, you do. But what they're doing is this. They do a bit of this. Yes, as a surgeon, I know that technical things are very important. Nobody wants a surgeon or a dentist who actually can't do the practical bits of what they do. And anything I say actually may not refer particularly to the technical elements of it, but the technical elements are only one part of it. And if you don't bring up people to be intelligent, thoughtful, understand what they're doing in this process, then you will actually fail the whole thing. But you know, the more I thought about it, the technical reasoning here is certainly how within surgery, as a technical profession, we have structured our curricula, we have structured our training, and we have structured our teaching. We have almost forgotten the process of phronesis, which, as we had, is the moral commitment to do the right thing in the right place for the right person. Because, of course, if that's not happening, then you do it. But as we've already heard, underpinning all of that is coming to terms and understanding the values and where that person is. And that is true of a patient-doctor relationship, where most has been written in medicine. But it is also true of the teacher-learner situation, where we are responsible, particularly in our domain, in teaching postgraduate doctors to gain their own agency. So phronesis, this idea of practical reasoning, underpinned our continuing thinking and actually led us to create what I think is actually a very valuable resource. Sorry. 5 minutes. Valuable resource, the clinical thinking pathway. The clinical thinking pathway is a model. It actually represents, I think, what we all do in clinical practice. Starts with a clinical problem here of the patient and ends with an action of the patient. It goes through a process of reasoning and then a process of deliberation. The green bits are the thinking bits. The purple bits are the judgment bits, the action bits. We divided this process into the top end of the pathway, which is rather formulaic. We've called it, and the terminology is ours, because when we started this 20 odd years ago, there was no terminology to actually classify what we were talking about in this area. That has improved. But the top end we've called clinical reasoning, rather formulaic, what we all do at the beginning of any clinical intervention. And the bottom end of the clinical pathway, deliberation, dealing with more complex things, using weighing up of maybe one or two, but often very many things that influence the future society, actions of what happens. This deliberative bit here is what doctors are about. We don't teach it, we teach this. This is binary, this is what AI can do. This is not what the thinking, wise doctor can do. I'm running out of time. We put in a continuum, a process of defining then, if they were making professional judgments, what was the quality of these judgments? Was it self-interested, maturing, or wise? This needed development, this was developing insight, and this was enlightened and growing. And you might say, Ed, I think that this is the road along growing towards mastery, if you like, although I know Della would hate that word, but this is self-interested really is keeping safe. The bit in the middle is actually where you're actually putting the patient first and you're thinking about the wider situation. And wisdom is actually where you can more or less, most of the time, put the patient at the center of what you're doing and come to what is best for them. Lots to talk about here, and you've got the papers on the table in front of you, I think. Time does not allow me to say too much more. The invisibles. Well, the other thing that we created and understood in this process of trying to define what professional judgment was, is that there are 6 influences to professional judgment. Context, the kind of person you bring to the table, the kind of professional you are, what you know, the therapeutic relationship you make with the patient, and the contextual awareness you have of the situation in which you're working. We put against these heuristics as ways of remembering them, and each had a reflective process that we've brought into the process of transformative reflection related to them. Context, the importance of interpretation, what kind of person you are, and at the bottom of all of this, the values that drive what you think and what you do. The kind of professional you are. Forms of knowledge, and we've identified 14 forms of knowledge, the blue and pink ones at the bottom here not being easily definable. Learned from practice, they are insights, they are things that actually come through being an experienced practitioner. And the therapeutic relationship and the other things. Having actually created those, we use them as a framework for reflective writing, and we use coloured writing, called rainbow writing, to get doctors to write about individual clinical cases. Having written using those as prompts, they then can interrogate them for the qualities of professional judgment and clinical reasoning that they used within those clinical scenarios. It looks a bit like this, sorry. This is writing actually from a trainee I was working with fairly recently. The writing is coloured. You're not meant to see what it is. You're meant to just look at the overall effect of the whole picture, really. But what you can see is coloured writing with my writing all over it. And we were doing this on Zoom because it was during COVID. And I used to scan these in and send them back. And then we would have a conversation about what I had written and what they had written. I could tell you a lot more, but we haven't got time. I'm happy to explore that in any sessions that we have. This process of creating the writing, however, gets people to sit down and write and think. It slows their brain down. It actually makes them have insights, that have gestalt moments while they're writing. It creates an opportunity to explore. This heuristic here we've used to try and say what we're doing in all of that. I'm keen to know how to teach and to assess professional judgment and clinical decision-making. Creating a narrative written by the person that you're trying to teach about something that they are interested in, and young doctors are very interested in the clinical cases that they have actually just been working with, and they enjoy telling you about them. We do that as grown-up doctors all the time. It's quite fun. You can then explore it, and insights develop out of that exploration of the narrative. This is very much related to their practice, what they're doing, And if this is discussed in detail with a supervisor who understands the process and is sensitive to what they're trying to do, it can reveal many things. We've also come to understand about the wisdom of the heart. And in our latest book, we do have a chapter on this. We've talked about emotions and how you feel. The heart is the emotional center of what we all know, both physically, it is important, and emotionally, it is a metaphor for what we're thinking. We have put the brain, a very simple mock-up of the brain here, inside the heart. We haven't taken the brain, the heart to the brain. We put the brain in the heart. And I could say more about that. But this heuristic is something that is quite scary to me as a surgeon to talk to people about. But it does involve talking about values and how people think. The person I worked with and taught me all this is Della Fish. Sadly, Della died last summer. But we are actually setting up a memorial fund, of which there will actually, I think, be some money around for maybe some research and setting up projects related to teaching this in practice. So if we're at the moment going through the Charities Commission to set this up. But I hope that actually we will be able to perpetuate the work of which she was very keen and which actually fits in with the whole philosophy of why this programme is set up today. I think I've had my time, so I better shut up. Thank you very much.